Is the world overreacting to the specter of Omicron, or is twice bitten, once shy the appropriate way forward? I'm Barkha Dutt. This is the Mojo Story. We'll be talking to experts from around the world, but first let's take you through the key developments of this extremely worrying specter of COVID that hangs over us yet again. The cases in India are rising, 21 at last count, and of course those numbers could increase. There has been global condemnation from experts of travel bans, making the point that they achieve nothing. South Africa's experts are pointing out that despite the surge, the hospitalization is low, the symptoms are mild, and doctors are reporting self-recovery by day 6 or 7 as distinct, in fact, from Delta. The world, of course, is taking no chances. There are talks of a third wave in India, and everywhere else too, there are all manners of renewed restrictions. Meanwhile, back home in India, you now have 50% of the adult population fully vaccinated, an important threshold, but one on which India can't rest. In fact, once again, the pandemic is being described as the pandemic of the unvaccinated. How should we be responding to Omicron, and has there been more panic than calm appraisal? Let's introduce our panel of global experts today. Professor Kogie Naidoo is joining us from Durban in South Africa today. Remember, it was South Africa that first revealed Omicron to the world. Welcome to the program, ma'am. Dr. Partha Kar is joining us from the United Kingdom. He is at the front line, a doctor with the country's NHS, the National Health Service. We're joined by Dr. Swapnil Parikh. Swapnil has been saying that you've got to prepare for a third wave, whether it comes or not. You cannot be over-prepared in this pandemic. Is he being reasonable, or is he being panicky? Not that he has a panicky personality. And we're joined finally by Dr. Ishwar Gilada, who's been making some very concrete suggestions, saying instead of panic, just go for the third shot. In India, we do not yet have a signal and all clear for what's called the booster, though some people say don't call it the booster because it's just actually completing the vaccination course with 3 shots. Let me start with you, Professor Kogie Naidoo from South Africa. What's it looking like in your country at this point? And, you know, some people have, of course, welcomed the news that the cases thus far are mild, but they've also linked it to the somewhat younger segments of the population that have been infected, saying South Africa has a young population, and where this virus hits the old, the results could be different. What are you seeing on the ground, ma'am?
So thank you very much for having me on your show, Barkha. So the first thing is that we are well and truly into our 4th wave of the COVID pandemic here in South Africa. Our trajectory of the epidemic is such that the daily number of positives are extremely high, far higher within the first 10 days than we've seen with the previous 2 variants that have circulated here in South Africa. The total number of infections exceed 16,000 new infections a day. The infections largely occurring amongst unvaccinated and, as you've rightly pointed out, amongst younger people in our population. The hospitalization rate, which is a very sensitive metric of our success in vaccination and on the virulence of the organism, still remains low. However, it's still a bit early to tell. And of course, death follows by a few weeks after COVID infections. And so we've yet to see a surge in mortality from this variant.
Mm-hmm. So if you were to then take that forward, you would say it's too early to heave a sigh of relief, because we've now had the WHO point out, Professor Naidoo, that despite Omicron in 38 countries, not a single death thus far. And thus far, by the way, and this is the really important point, vaccines are offering some protection because the vaccinated are doing better on the ground. This is what we're hearing from all the South African doctors we've been speaking to than the unvaccinated.
That's correct. Vaccination, yet again, we don't understand how the vaccines are protecting. But what we've seen in the past is vaccinations protect against hospitalization and death. That's what they're actually designed for. To a lesser extent, they protect against new infections. We're not seeing any protection against new infections due to the high transmissibility of this variant, but we're certainly seeing some benefit with respect to hospitalization. And certainly, when you look at the reports that have emerged over the weekend, even amongst those individuals that have been hospitalized, it's not primarily for COVID itself, but due to a comorbidity that got them into hospital, and they were concurrently diagnosed with COVID. So it is early days, Barkha. I think, as we've seen in the past, day 10, day 12 is when we start seeing the immune response to COVID that results in the COVID pneumonia and worsening clinical picture that drives people into hospitals. So we're now entering this week is going to be a very telling week for us in South Africa, because most of our early infections are now going to graduate in between day 10 and day 14, when if we are going to see a worsening clinical picture, need for oxygen therapy, need for hospitalization, we are likely to see it in the week ahead.
Okay, critical week. And the other important point is that thus far we have not seen, please correct me, Professor Naidoo, if I'm wrong, or anybody else, thus far we have not seen falling oxygen levels in Omicron positive patients. In fact, intriguingly, Dr. Partha Kar, the symptoms are also quite different. There's a new study out that actually draws the analogy with the common cold, saying that the Omicron variant has a lot more in common with the common cold than the respiratory symptoms we saw in Delta and Alpha. What's it looking like in the UK? There is, of course, a surge in cases, and I'm just wondering whether we're mistaking the tree for the woods, and whether the real crisis in terms of the number of cases continues to be Delta and not Omicron.
Yeah. So first of all, thank you very much for the invite. I completely agree, because we're in an interesting situation in the UK. We are a highly vaccinated country, right? So we've got licensing for age 12 plus, and nearly 80% of the population is nearly double vaccinated. You got a huge, nearly 35% are now had a booster dose. I mean, huge numbers. However, on the back of that, you've got, as you mentioned, a lot of cases going on. So yesterday we had about like 45,000 cases or something. So, and they're mostly Delta. There's all my Omicrons there. And I think you're absolutely right. We're talking about this new player, but the old one hasn't gone. And I think that's got enough of the risk. And I think it goes back to the initial message, which we keep saying, is that let's focus on the vaccines, focus on that. That's what gives you the protection. That's what you need.
But the vaccines are working in the United Kingdom, Partha, because the point is that while these cases are surging, you have not seen a commensurate increase in the ICU beds, or you've not seen that pressure on the hospital system.
No, nowhere near what we had in January. I mean, I was there on the wards. It was horrific in January and February. Absolutely nothing like that at the present moment. So I think there is a degree of caution that needs to be there. But it goes back to the initial point you said, is there a bit of an overreaction? Possibly there is, but once bitten, twice shy as well in the whole picture.
Well, England, where I am right now, is fully open still, despite some reintroduction of masks in indoor places. That's about the only new restriction that we've had thus far. Swapnil, let's bring you in. My argument is somewhat philosophical, and I know you keep saying the virus doesn't care about your philosophy, but I do think there's a mass psychological threshold that has been crossed here, which we need to factor into what can be government responses, and that is quite simply this. This world started by thinking it could eradicate or eliminate COVID, and now it's quite clear that all you can do is manage it. I don't think there's ever going to be in the near future a situation of a zero COVID cases. What should we be doing right now? You've actually used the phrase third wave on your Twitter timeline. Prepare for a third wave. Why do you think we might be looking at a third wave?
So firstly, let me just step back and acknowledge that there is a great deal of uncertainty. I would say there is a great deal of uncertainty even with what's going to play out in South Africa over the next 1 week. There's far more uncertainty about what's going to play out in India over the next 2 months. What there is no uncertainty in my mind about is that if we are going to have a third wave, the preparations needed to start yesterday. Not tomorrow, not day after, but yesterday. So with acknowledging that uncertainty, just for the viewers, so we understand what we're talking about, let's describe this under three headings. Transmissibility, how easily this spreads. Right now, we are seeing very, very rapid spread in South Africa, which is very, very concerning. And solidarity to all the doctors and the people there who are managing this, trying to manage this. It could be because the virus is intrinsically more transmissible, or there could be a certain amount of immune evasion, allowing better spread in partially immune, either due to vaccination or due to past infection, or it could be because of both. But we can't dispute that it is spreading very quickly. We talk about severity. Severity can depend on the intrinsic virulence of the organism. So, for example, we know SARS-CoV-1 is more virulent than SARS-CoV-2. We know that Delta was more virulent than ancestral strain. We don't know about the intrinsic virulence of Omicron variant. There is also the host factor to consider in host pathology. So how old is the host? Older, more severe disease. How are they immune? So have they been infected in the past? Are they vaccinated? That has some bearing. And do they have pre-existing illnesses? So as we start to see this shift go from the younger population, it's really important to acknowledge, in addition to younger population, based on studies on excess mortality, it's very likely that a very, very high percentage of South Africa has already been infected by SARS-CoV-2. So there is some amount of immunity at play that is going to blunt disease severity. The key question is, how is this going to behave when in a few weeks from now? What will severity look like when infections start spreading into the older population? And they are starting to spread, cases are starting to spread into the older populations now. What happens when older, sicker individuals with weaker immune systems, with weaker response?
But is this not a perennial? This is the seventh variant, right? This is the seventh variant, not the first. Is this now not a perennial reality? Let me take that to Dr. Gilada. As someone who's got COVID, lost my father to COVID, it is not that and has reported COVID for 2 years. I do not come from a space of detachment, emotional detachment on this. But realistically, how long can the world respond to a new variant and a new variant? And I know Swapnil will say the virus doesn't care. The virus doesn't care that you're tired. The virus doesn't care that you've had a psychological switch. I get that. But specifically, how long can this go on? I mean, I don't know. Swapnil, you study the history of pandemics. There must be a point where populations just say, we live with whatever's coming. Dr. Gilada, what's the first thing? India is not giving the third shot. Does that need to be urgently reviewed, or is the science not clear on that either?
Firstly, I would go with your philosophy. There is a symbiosis. We also live, virus, bacteria, fungi, parasite, everybody wants to live. And in all the pandemics we have seen in last so many decades or so many centuries, there is not a single pandemic which has finished entire human race. And that is not in their interest also. So it is possible that this milder virus has come. It will spread so fast and it will not give any morbidity and mortality or sizable morbidity. Then it is a good virus. Then we'll get everybody got herd immunity, and then we'll just have an endemicity every year. Some 1,000 cases will come and go. Now, your second question is why we are not deciding on booster on two issues. Number one, the committees which are sitting there, I don't know what they are doing. They sit on any kind of issue for months and months. For example, if you look at 12 to 17 year age group, Zycode is approved 3 months back by DCGI. Till today, not a single child has got it. So if there's something wrong, then you withdraw that license. And something not wrong, you start the vaccination. So the 2 or 3 days before, there is a body called INSACOG. INSACOG is supposed to look after only variants. They said that 40 plus should be given booster. Again, they are exceeding the brief. What is required for booster or additional dose? Additional dose for those people which are severely immunocompromised. Someone from the same learned body, they included even AIDS patient into severely immunocompromised people. They are not. HIV people who are on ART, they are as good as any other human being. So that cannot be part of the severely immunocompromised. So they need to decide, and I think today they are having a meeting, and they will decide on whether booster can be given to the frontliners like doctors and other frontline workers, and for severely immunocompromised. But what they need to also decide, if we do not use the current stock of vaccine, which is 30 crore vaccines lying with the state and many crore lying with the manufacturers, then this vaccine will be outdated, because tomorrow
Criminal.
manufacturers will be also going to have some new variant to be included in the vaccine.
Yeah, it
So
is
I think
criminal. It is criminal for any
listen,
vaccine to go waste. Yeah.
so I think we should start using as early as possible, remove the gap between two doses of vaccine, rush the vaccine to Africa and other countries who have not got even more than 5 or 7% vaccination. And it should be done as early as possible before the manufacturers start manufacturing another new vaccine.
Let's take this two very specific suggestions from you. Let's take this to our guests from England and South Africa today. Dr. Partha Kar, I know that in the UK, the big debate is over whether Boris Johnson had a Christmas party or Ted Downing had a Christmas party last year. But more specifically, actually, unlike India and South Africa, the anti-vaxxer movement is quite strong here. The politics here are much more polarized. There's a huge, ferocious debate over whether Christmas, is going to be shut down 2 years in a row. That takes me to what I keep telling Swapnil. There's a psychological threshold in this pandemic. Societies, political leaders, governments are no longer willing or able to respond like they did earlier. How much is that playing out, you think, in the UK?
I think there is a fair amount of it. I mean, people have responded. So it's a very interesting space to be. I agree with you completely. And I think the problem is, I probably hook on to what Swapnil said. The pandemic obviously doesn't care whether you're tired. The pandemic doesn't even care about your nationalism either. And that's what drives all these anti-vax movements, because you've got people doing their different things as they're going along. It just gives cannon fodder to people who want to make a case of why you don't need a vaccine. So you are in that space. At the moment, you do have a anti-vaccine movement here. People, you got quite big prominent personalities who will come out and say being challenged. It creates a lot of friction. But the other flip side of it is that we do have nearly 89% of people who have had taken the vaccine. But that's why we're waiting for the data from South Africa, because even if you get the little bit of percentage of people coming in, it's enough to overwhelm the system. That's the worry. That's the thing that we're waiting for. But I think my fundamental thing is, I mean, the point made about the stoppage, even we've had this in the UK, people sitting around going like, we're not quite sure when to give you the booster dose. In America have started, other places have started. And you're just wondering, why are people making this own decision? Why do people believe their science is better than somebody else's science? And I have never been able to get my head around it. And that drives the whole anti-vaccine philosophy, because people can feed off those uncertainties amongst clinicians and scientists in different parts of the world.
And you are definitely a supporter of the third shot, right, Partha?
Yeah, definitely.
Yeah.
Absolutely. Okay. Let's put it this way. My first conversation nowadays with the mom and dad who are based in India is, please keep an eye out when it opens and please make sure you go and have it. They're in their 80s. I am so keen that they have their third shot.
Yeah. And in fact, that's why I think the nomenclature also has to change. We have to call it the third shot and not the booster shot, because the booster suggests a kind of luxurious self-indulgence and not a necessity. Dr. Naidoo, what is South Africa struggling with the most? Is it the shortage of vaccines? Is it the hospital system? At the moment, what is the biggest crisis?
I think our biggest crisis is the low vaccination uptake amongst the eligible populations. As you've seen, it's just a quarter of the population that's fully vaccinated, equating to about 40% of the adult population. That is simply not enough. Our goal was to get to at least 60% of the adult population fully vaccinated by the end of December. And we still, December 2021, and we still have ways to go because the numbers of people presenting for vaccinations are not that great. We do have the suggestion of the third shot, mainly for healthcare workers and mainly amongst immune-compromised individuals, such as those that are receiving high-dose steroid therapy, chemotherapy, HIV-infected individuals with low CD4 counts are considered for a third shot currently. We have limited supply of vaccines. We all got in the third world countries, we got a bit late to the vaccine access. And so we're playing catch up. And so what we haven't done enough of is wide-scale education and infiltration of the poorest communities where there are vaccine sites that are readily available. So our biggest crisis right now is not the third shot just yet. but really it's about making vaccines more accessible and getting it into the arms of those that need it.
And one of the most irresponsible statements I believe to have come out recently, Swapnil, is from Moderna that basically suggested without data that the vaccines would have to be readapted, when practitioners are saying that we do not yet know how much protection the vaccines are offering against Omicron, or what the switch might be, but they're offering protection. And that is borne out by the fact that, the vaccinated are recovering even better from Omicron thus far. And I take Dr. Naidoo's point that we need to go into day 10, but thus far they are protecting. And the point is that when you see those kind of comments from Moderna, the anti-vaxxers actually just get stronger. But I want to come to the issue of travel, which is a bugbear of mine, because I think every time, this happens, the economy is hurt and there's a kind of travel apartheid and there's a kind of panic. And you've spoken about this, that there are other ways to do this. So go ahead with both travel and what practical things are, because by the way, this is going to be another excuse in India to keep schools closed. We've already had schools shut for 2 years. So, I'm really worried about these kind of things.
So, yeah, Barkha, I'll touch upon travel briefly, and then I'll return to your philosophical point, because I do have a perspective there.
Yeah.
I will not say that travel bans never have a place. I don't think that they are necessarily inherently racist. There are times at which they can offer some benefit, in the sense that they can prevent multiple introductions and multiple seeding events. But once you start having local community transmission, they just don't make sense. Very often what travel bans really are is they're a form of political appeasement to make the populace, to just give them a pacifier. You're stuck on this. Take this. This is what we're doing for you. We're not actually doing anything, but we're giving the perception that something is being done. Now, if we wanted to be smart about this, like, we would of course require vaccination for travel. I think that's something that most of us can get on board with. We should require pre-departure testing, and we should require post-arrival testing. What I would do is PCR before travel, PCR on arrival, hand a pack of N95 or FFP2 masks to people who are coming in a situation.
Why do you need PCR at departure and destination when there's probably a gap of 3 days? You don't need a PCR test every 3 days.
You can go from PCR negative to highly infectious in about 48 hours, 72 hours. And not one test is not going to prevent all introductions. So I would take it even beyond the one PCR on arrival. Like, I would say we should look at, in a situation where there is a variant that we are concerned about and where there's uncertainty, we don't necessarily have to use PCR. We could use proctored home rapid antigen tests serially every day for about 7 days. People could perform them on a video. We could even look at genomic sequencing of sewage from planes. This has been used in Australia rather successfully. So there are many innovative strategies to use besides inconveniencing the individual. We can build systems around it. To your question about how much longer do we have to keep living like this, it's not going to be forever. I can't give you a timeline, but it's not going to be like this forever. I think one of the mistakes we make is that, we're reacting to a new variant this year, so we'll be reacting to a new variant next year. SARS-CoV-2, when it emerged, we were entirely naive to it. It wasn't like influenza, where we've had exposure to various other influenza viruses, and that there is some overlap. We were entirely naive to this virus. I do think that, it's slightly controversial opinion, but I do think most people are going to get exposed to this numerous times. I'm not saying that that's what I want. I'm not saying I want people to get infected. I'm just talking what's going to happen is that most people are going to get exposed to different variants, even individuals who are vaccinated. And over time, our immune repertoire will build up so that we won't have epidemic levels of transmission. We may have seasonal increases, but I certainly don't think it's going to be like this forever. If I may just comment on why it's important right now, briefly. So I just want to give you some maths, the maths of exponential increase. So let's say we have a variant, and these are just numbers as an example. Don't focus on the numbers, focus on the principles. Let's say that we have a variant that 5% of those who are infected need oxygen and 1% die. If there are 10 million infections, 500,000 people will need oxygen and 100,000 will die. Now, let's assume with a intrinsically less virulent variant, or one that is less pathogenic because it's blunted by immunity, let's say only 2.5% need oxygen and only 0.5% die, but there are 4x as many infections. That's 1 million people who need oxygen and 200,000 who die. Or let's say that there are the same number of infections, but instead of occurring over 2 months, they occur over 2 weeks. Then your health system will get overwhelmed. During the second wave, health capacity wasn't just exceeded by a little bit, it was exceeded multiple times over what it could handle. So if we have a third wave and it's much smaller, but it exceeds our capacity to care for the infected, we'll still have a crisis.
And which is why I think there is now a consensus that field hospitals, those big facilities that can be readapted at any point, oxygenated beds, I think those preparations, no one has any disagreement or dispute with. I think it's just that from saving lives, if you're going to shrink the very idea of life, how long can you live like this was my philosophical question. Dr. Gilada, I want to draw your attention to another number, and then I'll take last comments from Dr. Naidoo and Partha. 12.5 crore people are due for their second dose in India and have not shown up. And I'll come back to my favorite topic. Do states need to mandate vaccines? Some states within India have begun to do this. Puducherry has done it. You've got Telangana saying show your vaccine QR code to enter malls. You've got Kerala saying no free treatment if you're not doubly vaccinated. Dr. Gilada?
I think we need to have both approaches, carrot and stick approaches, and also look at some of the very advanced states like Maharashtra and Tamil Nadu. They have taken up a space of Madhya Pradesh and Rajasthan. Their vaccination is much better than Maharashtra and Tamil Nadu. So there is some kind of relative hesitancy among people by themselves and by the managerial people who are increasing that hesitancy. If you are having a vaccination at a gap of 4 weeks, 5 weeks, 6 weeks, people remember. If you have at a gap of 12 or 16 weeks, they don't remember, they don't want to come back. So I think we should reduce that kind of hesitancy. Secondly, there is some kind of religious hesitancy. Again, I will call it only relative hesitancy. In Jammu and Kashmir, 100% first dose, 98.5% second dose. And why in Bhiwandi and Malegaon it is not happening? So I think we should look at those issues also and solve those issues. I think our system is not looking at all kind of solutions. They are doing the same experiment and we are waiting for a different outcome, which is not going to happen.
What's the one thing that should happen immediately, Dr. Gilada, in India?
We should immediately reduce the gap between 2 doses, and that will happen probably today if they have some sanity left. And secondly, we should rush the vaccination as early as possible to Africa or any countries where vaccine is very poor. I think we should look after them more than ourselves.
So you're saying before India looks at third shots, we should be sending vaccines to Africa?
Sure, because when you have a third shot, you increase immunity by 8%, 10%. But if you are giving the vaccine to people who have not got it, you get an immunity of 80, 90%. So do we look after 80, 90% or just 8 or 10%? So yes, a third shot is required, booster shot is required, but for limited number of people. Even for healthcare workers, why we require third shot is their confidence building mechanism that, look, we have given you third shot, be ready if at all the third wave comes.
Yeah. Partha, one of the things that I think you do want to focus on is what about people with comorbidities and what about other health problems? One of the things we saw in India was tuberculosis just spiking, cancer patients having nowhere to go, dialysis patients unable to get a dialysis. We just are so singularly focused on this pandemic, we have forgotten other ailments that need hospitalization and doctors.
Let me give you one very simple example. We are blessed by data in the UK. That's one thing we have, lots and lots of data. We've got very clear examples that if you don't do the 8-care process, checking blood pressure, cholesterol, etc., and people with diabetes, they have got worse outcomes. That number has dropped to less than 20%, right? So right now we've got a possible third wave, fourth wave, wherever we are at Omicron. Guess what's happening? People are saying, oh, let's just suspend the diabetes process or whatever. And you're going like, how far do you want to push this back? Where do you stop? Because these people also have their lives and they are dying beyond COVID. So I think there is that massive, massive problem. You mentioned schools. That's a massive worry for children and the developer. How far do you keep pushing back?
Yeah. And unlike the UK, in India, physical schooling was just about to open. Then you had pollution in cities like Delhi, which shut it. Now you have Omicron. It is an insane situation that you are going to keep children out of physical school for 2 years. I mean, it is an unimaginable situation. Dr. Naidoo, Professor Naidoo, I'll give you the last word. I was talking to one of your colleagues, Angelique Kwetsi, who first sort of found Omicron on a rapid antigen test. I just want to underline that, not even on a PCR. And she said she was cautiously optimistic. Would you share that cautious optimism, or are you somewhat more concerned at this juncture in the trajectory of Omicron?
I share the cautious optimism, given the anecdotal reports that are emerging from the ground that this is largely a mild, even mainly asymptomatic infection amongst individuals that have been caring for, doctors that have been caring for newly diagnosed patients with Omicron. I'm optimistic because our vaccines were developed based on the wild type, the wild strain of COVID-19, and they still worked against all the variants that have emerged subsequently. So I am optimistic that the vaccine will work against this strain too. And I want to remind everyone that non-pharmaceutical interventions, social distancing, and mask use actually work. And we must not forget to reinforce that education as we try to curb the spread. We like biomedical interventions. It makes us feel comfortable. So vaccines are always prioritized, but we have some simple measures within our reach that we all should universally practice in order to curb transmission levels.
And I will just end by saying, if you have not got your second jab in a country where the vaccine is available to you, you are now part of the problem. And this is no longer about an infringement of your freedom, but it is an infringement of the right to health, life, and livelihood of everybody around you. So, literally, I think states are going to explore different forms of vaccine mandates. You have Indian states now that are saying you cannot enter malls and movie theaters without showing proof of jabs. I think in the UK, where the country is highly vaccinated, you don't need that proof because the percentages speak for themselves. But in India, where like almost 13 crore people have not shown up for their scheduled second jab, maybe linking it to economic and social activity is something that will get them at that vaccine center. Thank you so much. This has been highly interesting and illuminating. Professor Naidoo, to the people of South Africa in particular, our solidarity and our gratitude actually for revealing this to the world with such exemplar transparency. I think that needs to be acknowledged. So thank you for that, Dr. Partha Kar, Swapnil, and Ishwar. As always, a pleasure having you. To our audience, see you tomorrow. Thanks for watching. Goodbye.
It's great to see you here. Thank you for watching our work. If you haven't subscribed yet, don't forget to click the bell icon and subscribe to Mojo Story and support independent, robust journalism.